Today I'm getting liposuction of the arms and the upper bra area. I'm excited today to have Dr. Klein do the procedure, as not only is he the inventor, but just an expert in all areas of what he's doing today, and just super excited for the results and to see how everything turns out.
So this is a bag, I call it a reservoir bag of tumescent epinephrine lidocaine, TEL. And this has 0.8% lidocaine with some epinephrine. We're going to infiltrate that painlessly into her arm. The goal is to make this painless. So the whole procedure, putting the local anesthetic in and also doing the liposuction, should be completely painless. This is somewhat of a wet procedure because we're squirting using a peristaltic pump. We start off with this, just a few little areas. There's one little spot that's anesthetized. I just jab it like that. The needle is so small, all she can feel generally is the needle hub hitting the skin, but not the needle. And now it's infiltrating. The pump is going at 15 RPM. I have a 32 gauge needle, 4 millimeters long, and it is very small and basically painless injection. So this technique, using tumescent epinephrine lidocaine, TEL, was developed in 1985. Eventually, it became a technique which we're using today as a form of drug delivery. So we can put different types of FDA-approved injectable drugs, or a combination of those drugs, into that solution and inject them under the skin, and it puts the drugs right where we want them. It avoids having to give drugs systemically when you have a localized pathology or localized lesion. We just treat the lesion itself by injecting the drugs interstitially or between the cells right into the site of the problem. A 25 gauge 2-inch needle and a 22 gauge 2-inch needle. Start off with the 25 and then go to the 22 and maybe even a 20 gauge needle. You will see the vasoconstriction. And the vasoconstriction is the capillaries being constricted by the epinephrine in the solution. We can do liposuction with no bleeding because all of the little capillaries are constricted. So before this technique, liposuction was done under general anesthesia. Almost everybody required an autologous blood transfusion. That means they donated their own blood 2 weeks before their surgery. And because there was so much bleeding, they had to have a blood transfusion after the surgery. And then once this technique became known, that no longer is the case. If the surgeon is technically capable of doing what I'm doing, or he's trained his nurses to do this, then general anesthesia is absolutely not necessary for liposuction. But if the surgeon has not been trained to do this, or is unwilling to do it, and it's more convenient for him to do it under general, then they'll get general anesthesia in addition to this. There's a big advantage to doing it under local. If you're doing it under general anesthesia, they're in an operating room with an anesthesiologist and the clock is ticking. They're paying by the minute almost for that operating room facility. So they don't have time to let this drug take effect after the infiltration. And that's the real key to having a really perfect tumescent anesthesia, is putting the local anesthetic in painlessly, and then waiting up to an hour or more for that to take effect. And once all that has taken effect, the anesthesia is profound and the vasoconstriction is complete, and one can get much better results by waiting. But if you're in a hurry because you don't have the time to wait after putting in the local anesthesia, then the only recourse is to use less of the local anesthetic so it doesn't get so tumescent. And then without that complete tumescence, there's more problems, more bleeding. So now I'm going to go here under the skin, come up here, and I'm infiltrating right there. Now the infiltration is going right there, and that's going to anesthetize the skin. So when I put the needle here, it's not painful. It's already anesthetized, so I can hop along this area I'm treating by anesthetizing this area and then anesthetizing that, put the needle there, and keep on going. The convenient part for me is that I've trained my nurses, and they're very good at this. So I don't have to do it, and I don't have to pay for an expensive operating room. I just do it in my office. Since I've been doing this since 1985, we've never had any infections, We've never had any complications to speak of. The most common complication I've experienced is patients having unrealistic expectations. So that was my fault. I didn't explain exactly what we were going to see at the end of the result, and they were expecting things that were impossible to achieve, and then they were disappointed. I can use the same technique to treat other conditions that are very painful. For example, if someone has shingles, I can anesthetize the entire area in about a half hour, and they have no pain for at least 24 hours or more. And then if I put acyclovir in that solution, that's an antiviral drug, then we can stop the progression of the disease very quickly. So instead of having pain for weeks, they have pain for a couple days. That's it. Okay, so that was a 25 gauge needle. I'm going to switch now to a 22 gauge, which will go a little faster. So this can be done in a doctor's office, like my office, with the nurses doing it, or you can go into an operating room and have the anesthesiologist put the patient to sleep and then give half the amount of tumescent anesthesia that is required to get good results and do liposuction. The patient doesn't feel it, but there's considerable more bleeding occurring, and the risk for complications is considerable. About 20 years ago, two physicians, one a plastic surgeon and one an anesthesiologist, conducted a survey of plastic surgeons who did this procedure, cosmetic surgeons, and they asked them, are you aware of any cases in which there was a fatality for liposuction? And they received quite a number of responses, like 125 or something. The questions also said, was the surgeon a plastic surgeon or was the surgeon a dermatologist? And when they got the survey back, there were no dermatologists associated with a fatality. So when they published their results, they didn't even mention the fact that there were no dermatologists who had fatalities. They just said fatalities were associated with cosmetic surgeons. They didn't even use the word plastic surgeons, although all the surgeons were plastic surgeons. So it was a little bit of a political scientific report. But it's a shame that they didn't say that there were no deaths associated with the technique that dermatologists use, which is this technique, totally by local anesthesia. If they had, plastic surgeons would be using this technique and patients would have a safer procedure. I should say not all dermatologists can do this procedure. Not all dermatologists even want to do the procedure. But amongst those that do, there are very good results and very good liposuction surgeons. There are far more plastic surgeons these days doing liposuction than dermatologists. I think dermatologists would prefer to inject fillers and Botox. Michelle, tell me, how are you doing so far?
I'm feeling good.
How about the pain level? Have you experienced much pain?
No more than a little stick of like a regular, like a little shot.
A little twinge here and there?
Yeah.
Okay. This is the technique we use with the hypodermic needles for many procedures that don't involve liposuction. So if someone has a big skin excision, we can do this, especially on areas like the neck, the face, areas where a big cannula under the skin is not appropriate. When we're putting a cannula into a subcutaneous fat, that works well. If a patient is very skinny and doesn't have much subcutaneous fat, a cannula doesn't work very well. This is the safest and the most effective technique. So I'm going to show you a technique for doing tumescent anesthesia with a cannula. First I'll make a couple anesthetic blebs here. Then I will do a little more local with a hypodermic needle, just around this point of entry. You can see the little white areas there, been anesthetized already. This is all going into subcutaneous fat. It's not going into skin. And it's relatively superficial. We're not getting anywhere near ribs or muscles. As a 1 millimeter punch, I make a little hole here where I can put a cannula. Goes through the skin. I'm showing both techniques now. But now I'm going to use a slightly larger needle and just go very superficially and just fan out, not very intensely, but effectively. You're a champion. You did great. Can you just tell us how much discomfort were you in?
I am in zero discomfort.
Zero discomfort, okay. We'll let this take effect now. We like to let this sit here for at least an hour.
Okay.
Now we've already done the other side, so that's been detumescing. I mean, detumescent means the swelling is going down and all the medication is oozing into all the little nooks and crannies and soaking all the nerves and all the capillaries, so it's becoming much, much more effective. It's vital that we wait at least an hour and sometimes longer to get the best results. You get almost zero bleeding. In fact, my patients, when we do liposuction, they lose more blood at the preoperative exam when we take blood from their arm just to make sure they're okay. They lose more blood on that day than they do during the liposuction. All right, I'll be back.